to log on because I clicked on the link. Hopefully,
Oh
can.
yeah, you might have to.
Yeah, I did through my laptop. I'm not sure if it worked on my phone. If not, it's okay.
Okay. All right. Well, thanks for joining me today. I've got a very special guest, Grace Bernals, who's a speech and language pathologist. And so it's a really interesting area and crossover between orofacial and dental development that I'm seeing in the clinic and speech development that, parents, but also a lot of great practitioners out there who are helping parents and kids to develop their oromotive function to make better sounds. It's such an important area that I don't think is educated well enough. Grace Bernals, thank you for joining me today.
Of course. Thanks so much, Dr. Lynn. I feel so honored to be here. Thanks so much for having me. I'd love to talk all about orofacial malfunction disorders and speech. Unfortunately, we didn't learn about it so much in school, so I had to do a lot of extra courses after.
Yeah, and I wanted to dive into that, like a little bit of the disconnection and some of the, because speech and pathology and so forth, there is a big crossover between orofacial myology, but that isn't traditionally taught. But I thought we'd go back first to a little bit of your experience and some of your motivations to go into pediatric speech and language pathology. And what were your kind of initial thoughts when on how important this area is?
Yeah, so growing up, I knew I wanted to work with kids, something medical related, something where I did help children, and I came across speech language pathology, and I knew I only wanted to work with children, hence why I did pediatrics, and just being in the field for about 10 years now, I just felt like I was missing something, especially when it came to articulation skills. I've had kids where they're on my caseload just working on those R sounds or S's, receiving speech therapy consistently, and they're just still not getting it. And I learned a little bit about myofunctional therapy prior to that, but because we didn't learn about it in school, it wasn't something that really went to my mind immediately. So I decided to take some courses, and that's when I just feel like all the missing puzzle pieces just went together, just because as SLPs, we do look a lot in the mouth. We do look obviously at articulation, and with articulation to be.
Oh, we've just dropped out there. Grace will just be back in a second.
Hello? Oh.
There you go. You're back.
Oh, did you lose me?
Yeah, all good. Yeah. So you're on articulation.
Oh, yes, yes. So as far as articulation goes, it's really important for children to be able to use those articulators, the lips, the tongue, the cheek, the teeth correctly to be able to produce those sounds accurately. So yes, I just love both of them combined together.
Absolutely. It's oh, we've lost her again. It's such an important connection that actually isn't communicated very well, that the early or motor development is affected by the teeth. And this is something that the dentists aren't educated very much about either, which is, really why, I find your work so interesting and important, that SLPs have this key for early orofacial development that a lot of, parents, but also practitioners probably aren't aware of, that they can be picking up these early signs. And you guys are such magicians at getting like kids to do, to learn skills. And that's something I want to kind of dive into, is some of that skill set, because it's really important. It's difficult to do in the dental setting.
Yeah.
It is. So it's like SLPs play a huge role. Like, we love our referral to our SLP who's orofacial trained as well. But it's a thing that I think a lot of parents are experiencing but don't really understand. What would you say are the main things that parents are noticing and experiencing with their kids in terms of early development and sound, development in kids? What are they noticing and experiencing today?
So I'm noticing a lot of them are mouth breathers, and with the mouth breather, obviously, as you know, the tongue is resting low, and when their tongue is resting low, a lot of sounds are not produced correctly. So if they don't have that good lip closure, then they're not able to produce bilabial sounds like the P, the M, the B, that requires that good lip seal. Now, if there's, let's say you have someone that was a thumb sucker for a long time, that's also affecting the teeth formation, creating that open bite in the teeth, which can affect a lot of sounds like the S, the T, the D. affecting the airflow, you might hear a lisp when they have that. And then, of course, if there's a tongue tie, which I not obviously not everyone with articulation skills have a tongue tie, but I do have a lot of kids who have a tongue tie or restriction there, and they're having a difficult time producing the R sounds, the L, the T, D, N, that requires a lot of that tongue elevation. So I would say a lot of the kids I see fall in those areas.
So you mentioned before that this kind of identification of physical anatomical issues isn't specifically, or it isn't really taught across SLP training. So what was your kind of experience as an early practitioner in terms of, maybe before you were thinking about how the development was affecting sounds, and how this was kind of, maybe not progressing in a child's therapy?
Right, yeah. So we did do some oral motor exams, but it wasn't as detailed as I do now. So we of course look at the tongue mobility, we look at the hard palate, we look at jaw dissociation, making sure the child is not moving their jaw along with their tongue to produce those sounds. But that was mostly it, along with maybe listening to obviously the sounds and how fast they're able to produce certain sounds, given the speed. So with that, then I'll do a lot of visual cues, having them look at my mouth. We will we will still make sure that the child is using correct tongue placement, but oftentimes, if you're doing the tongue placement and there's really a restriction down there, I don't realize it. I just think like, okay, well, you got to do it. Come on, get the tongue up. But then after so long, you can only do so much, and the child can only endure so much too. So after that, then the child is burnt out. Not always, but it did happen for a few cases, and I just hope that in grad school now, hopefully, there's more schools, or at least that are trying to incorporate this, because I really wish I learned about this much sooner.
Yeah, I think you're probably describing maybe a frustrating situation for parents and practitioners even, that are, they're doing everything in the book. The kid's trying, right? We have this experience too, where the kid is trying, and they're young, and they're like going through these kind of therapies is a lot of energy for them, and they get a bit sick of it. So everyone, the parent, the practitioner, and the child is tired, and they're kind of like, well, we're not getting anywhere. Like, would you say that's a common experience with SLPs today? Like, is that something that, that kids are experiencing a lot, how these therapies need other kind of analysis to help a child move forward?
Yeah, so I'm not saying it happens to all children, but I can say from what I've heard from parents that have reached out to me, and just from some of my experience, I have heard that it does happen often. And that's because, the child just kind of stuck, physically, structurally. But of course, there are some cases where, for example, I had an adult with a very severe tongue restriction, but he's able to produce the sounds fine, but he was compensating so much his whole life. So some of these kids can maybe progress and be able to do the sounds, but they may be compensating in ways where they're moving their jaw when they shouldn't be moving their jaw, or using other muscles in the face. But yeah, I would say I'm hearing a lot of families that have come to me recently where they're just like, well, they've been stuck with this therapy, so with the sound and speech therapy, so we want to try something different.
Sure, and for parents that are, I've got 5 young children, so it's like you see a lot of this, and there's so much going on in those stages. I think, like, it's not well kind of understood exactly what a parent should be looking out for in terms of early, speech and language development. So, can you help us kind of understand some of the stages, like the earliest stages, in terms of what a growing baby and then into a toddler should be parents should be looking out for in terms of language development?
Yeah, sure. Of course, in the early stages, the beginning stages, you wait for the cooing, a lot of babbling. And then as the babbling progresses, you hear more variegated babbling, like badaga, badaga, ba 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 ba. And usually, once the child hits at 1 years old, between 10 to 1 years old is around the time when the true word appears. And what I mean by true word is a child producing it consistently? Are they saying it on their
Oh, we've popped out again.
either? Uh,
Yeah, we're here.
Yeah, and of course they don't have to say that word accurately either. I don't know if it got cut off anywhere there.
Yeah, so we got to 12 months. Yeah, so, saying a word truly, yep.
Yeah, so truly by 12 months old, they should be saying those words. And then, of course, speech sounds, because I know we were going to talk about this. I actually have this chart. I don't know if you can see that. So this, can you see that? Okay, so this shows the speech sounds that are produced by age. So, for example, by 2 to 3 years old, they should be producing the P, the B, the M, the D, N, H, T, K, G, W, N, F, Y sounds. So those are the earlier 2 to 3 year old sounds. And then after that progresses, 4 years old, they should be producing the L sound, the Y sound, the ch, the sh, the zh, the z sound. And then 5 years old should be the R's. And the R's are the hardest sound to produce. So I do have a lot of R clients, and that's usually by 5 years old. The R, the zh, the, and then finally the six is the other th. We have the two, the voice th, which is a th, and then the voiceless, which is a th. So that's
Oh, we dropped out again.
it keeps getting cut off. Okay.
That's okay.
I don't know what was the last thing you heard.
Yeah, so the stage, I think that's really useful. So the earlier stages, you have these sounds. Can you tell us a little bit about what are some of the orofacial like what is the child doing with their mouth while they're making these sounds as they're developing? And what can a parent maybe pick up visually in terms of that?
Yeah, so for those bilabial sounds, so those ones that we use our lips, so the P, the B, and M, so parents can look for, are they using that good lip seal? So versus doing maybe a, for, so like for the PBM sound, see that they're using that good lip closer versus going like or like instead of more, it might be or. So maybe looking at that. And then for those sounds that require tongue elevation, like the T, D, and L, see where their tongue is going. Ideally, we like it a little bit behind our teeth, like that. So if they're producing it more like for the L might be L versus la. Same with the N. with,
So,
with the R sounds, it's very common. A lot of kids will do that with the W. So making sure the child is not rounding their lips for those R's. So maybe they're saying red, they might be saying wed. We want our lips to be retracted. Red.
oh. Yeah,
Yeah.
so ours, I think, is a difficult, you said that's roughly at about 5 that a child should be developing an R sound, is that
Yeah,
right?
that's
Yeah,
correct.
okay. And so what are some of because obviously this is something quite commonly that parents do pick up. What are some of the signs that, or the oromotor movements that it creates an R?
What are, can you say that again? What are the sounds or?
Yeah, sorry, the movements in the mouth that creates that R that a lot of kids have troubles with.
Right. So oftentimes kids might round their lips for the R. So we want our tongue to be retracted and back. So I'll often use a mouth model, showing where the tongue goes. So ideally, when we produce that R sound, we want it more touching our upper back molars here.
Mhm.
First, and I'll try to show the child. I'll either maybe, here, I'll show you a tool that I use. Sometimes I'll either use like a tool that kind of vibrates, and I'll either touch that part or teeth part. So I'll use like a lollipop to touch the back teeth just so that the child knows where to lift up their tongue. But of course, that can be tricky with kids who are severely restricted to get that tongue up and back as well. But really, a lot of visual cues, tactile cues, a lot of practice, of course, too. I do provide homework for the families to work on throughout the week.
And when a child is experiencing, so you mentioned this kind of connection between, low tongue posture and mouth breathing, open mouth posture, and, the mouth seal as being, critical for some of the early speech, development. So as you're starting to see that okay, maybe there's a this child is struggling, and then maybe some therapy hasn't kind of pushed this sound along. Where do you start to think about this orofacial development? I'd imagine you start to look at it quite early now, but
Mhm.
where would you say that there is maybe a referral pattern that's starting to occur there? And what have you found in your clinic in terms of this?
So ever since I started myofunctional therapy, I look at it from the very beginning. So if, depending on what the parents' concerns are, if they come to me primarily with articulation, then that's when I do my comprehensive evaluation. So looking at the mouth, looking at the palate, looking at any possible tongue or lip restriction, and that kind of helps me figure out a game plan of where we'll head. If it's a very obvious restriction, then that's when I would refer out to, some providers here who are tongue size specialists. If there's, of course, mouth breathing issues or severe enlarged tonsils, I'll reach out to airway ENT. But if I see that the child does have good tongue mobility, they're not compensating their jaw so much, and that in that case, I'll do a little bit of speech therapy with still some tongue exercises and increasing nasal breathing as well. See how they go. But if we're kind of at a point where we're really stuck and the child really has a difficult time moving forward, then that's when I may discuss with the parents. Hey, I think we may need to you may need to see this tongue tie specialist to kind of see the structural aspect of it to see if a release would be beneficial, especially if that child is kind of stuck as far as producing certain sounds because of that restriction.
And have you seen, in terms of results, we've kind of noticed, probably mixed results in terms of releases, in terms of, how a child actually progresses after a release. So, what are your experiences in the clinic with how children that are struggling with sound development and after a release, and, which ones have benefits and maybe some that aren't progressing still?
Right. So from the very beginning, I do tell parents, once we do the tongue tie release, I want you to know that it won't be an immediate, they won't be producing that sound immediately correctly, like all of a sudden, because sometimes they don't. And I did have one client, he is 10. He was working on R's for the longest time. He had R's a little bit here and there, but it wasn't as consistent. But once he did get the tongue tie release, this is a recent one, he was able to say them much clearer when we practice. However, once he starts talking in conversation, it's like he forgets the correct production. So yes, I've seen where they are able to produce those sounds correctly, shortly after, especially if they've already been receiving speech therapy. But it's a case of, well, are they able to generalize that skill now to remember to produce those sounds the way they should be produced, if that makes sense. So I definitely have seen kids where they do benefit a lot from it, and then I do have some where they are able to produce it correctly. But again, they still have to practice that correct tongue placement because their tongue was so used to that initial position already.
It's an interesting connection you've described there between the understanding of motor movements for sounds,
Mhm.
but then the consolidation into what is language and what is somewhat maybe intuitive. What are some of the neural development stages that you guys understand in terms of what a child has to kind of understand to make a motor movement for a sound, but then the integration into language and communication?
Yeah, yeah, great question. So as far as, when we start doing sounds early on, what's key is of course is awareness. So for example, I will do a lot of I do a lot of comparison between one sound versus the other. So if, for example, if the child is producing red, but they're saying it as wed, I'll do what we call what is the term? Basically, you're comparing different sounds. So if they say red, I'll say wed. Which one sounds correct? One or two. Now let me say red. Which one sounds like a good R? So making sure that they're aware of that first, and then once they understand that. I do start off at the isolation level, the syllable level. So we'll do it in different vowels like ru, ro, ra, re, ri, ro. Once they're good with that, we move on to the single level. And then once you're good with that, do the two-word phrase level, longer phrases, sentences. And then the last thing is really conversation and doing that generalization. So it's gradual. It doesn't go straight into like, okay, we need to say that in a sentence now that we're teaching, I'm teaching the R sound. So it's definitely a ladder.
yeah, that children. Oh, we've just dropped out there. So yeah, we were talking about how children are developing certain sounds and the neural development that goes alongside. The Where do you place your orofacial analysis now when you assess a child? And because you talk about sleep a lot in on your Instagram and what you publish online. So how do you assess how a child sleeps? Because something that I see a lot is that kids that don't sleep very well, and this is very much connected into breathing. This is something we look at closely.
Mhm.
Is that when they're not breathing and sleeping very well, they're maybe not integrating some of these skills and so forth. And there's other areas that are affected. Parents will sometimes, talk about learning, but like, are there other things that you're noticing in the kids that aren't breathing and sleeping very well? Yeah,
Uh,
so we just say about the breathing and sleep, how that connects into how a child actually learns and consolidates skills and memories.
Yeah, so it's a lot of it is a parent questionnaire for one. I'll ask them like, okay, well, how are they sleeping? Are they snoring? Are they mouth breathers? Do they sleep restlessly? Do they move around in their sleep? Do they seem to be well rested? Sometimes parents will say like, oh, they're sleeping fine. I don't hear any snoring. They seem fine. But when I ask like, do they seem tired in the day? And then sometimes they say yes. Or do they seem hyperactive in the day? And they say yes. And that's where, for one, I have this one child, he did just get diagnosed with ADHD, and parents just have been telling me a lot, well, he's sleeping fine. He doesn't seem to be snoring. But I did remind them there is that connection, and which does affect, our sessions sometimes. So in our sessions, I have to incorporate a lot of movement. So which can be tricky for parents. I'll try to give them some tips on how they can incorporate movement at home if their child does have difficulty moving around. If their sleep and breathing is affected.
And you mentioned the diagnosis of ADHD in connection to sleep, and I imagine that would potentially make some difficulties with the kind of therapies that you're enacting with kids.
Hmm.
What have you noticed with this with parents that are and kids that are being given or this potential diagnosis and connections into their development? Like, are you seeing a link there or anything associated?
Yeah, I definitely do. Like the few cases I have with ADHD, I do see that they have a narrow palate. Their tongue is not resting at the top; it's resting low. They're more mouth breathers and nasal breathers. So I definitely see a connection as far as that goes, especially because they're not getting that good quality of sleep, even if the parents feel like they are. But once I tell them, why don't you go in there, watch how they're sleeping, try that too.
There we go.
What was I saying? So yes, I do see a strong connection with ADHD, that limited attention span, that hyperactivity when it comes to breathing and sleep. So I definitely believe it.
And you mentioned that you kind of integrate orofacial myofunctional therapy, sometimes with kids, and you've posted some cases as well. How, and you mentioned jaw kind of posturing, and it's something that I noticed nearly globally along kids, even with kids that aren't significantly tired, is that
Mhm.
their tongue and lower jaw moves together, and
Right.
they have no awareness of how to move the tongue without moving the lower jaw. And so do some, like, in terms of your how you treat a child, is it becoming foundational? Sorry, Grace. I was saying, is it becoming foundational how you assess a child? Because this you mentioned this jaw posturing. This is something that I'm seeing very, very commonly in kids. And so, are you starting to to build them foundations in orofacial therapy first? In a majority of cases, or how are you approaching this?
Yeah. So a lot of kids with that jaw sliding or jaw protrusion, I'll use either bite blocks or I have these biting blocks that you would put them between their teeth. That way, it helps stabilize their jaw to either lift up their tongue. That can also help with vowels and consonants. There's different sizes to these. So I'll use those, or I'll use a regular bite block to kind of help them maintain their jaw. Then of course there are kids that do want to keep their jaw still, and they try so hard by using their hands and like holding their jaw in place. So we definitely do a lot of the bite blocks. I make sure that they're aware of that, and I always use a mirror as well, so that they're seeing how they're moving their mouth, their lips, their tongue for these sounds and words.
And it seems to me that sometimes it is because, tongue ties affect everyone differently, as far as I've noticed. Some kids will be, very restricted, and as you said, they kind of they deal with it, right? And you
Mhm.
have these adults that have got severe restrictions, and they've been, functioning all their life, more or
Yeah.
less fine, but couldn't poke their tongue out their entire life.
Mhm.
But then others, and in children, you kind of notice that they're very, very affected. Like this, a child not being able to move their tongue sometimes, severely inhibits their breathing there, but also to the jaw posture is very, very affected, as you've discussed. The one big connection there is the swallow motion and into feeding as well. I mean, how do you see this connection into early feeding patterns? So, Grace, we're just saying about into the connection between early feeding, because the tongue obviously is the director of swallow. Do you see that sometimes that feeding is an issue in these cases where you see this jaw dysfunction too?
Yeah, definitely. When it comes to feeding, we use our tongue for everything. We move our tongue side to side when we move our food from one side to the next, and we use our tongue with that. So if their child is not even able to do that, that will make it tricky to swallow food. Oftentimes, when I see children swallow with oral dysfunction, they tend to kind of swallow with their tongue out. They might do that, or maybe they don't have that good lip seal to even swallow or chew their food. So then you'll see some spillage when it comes to chewing, eating, maybe drinking. So I do see a lot of that being affected with the jaw and everything else, all the other articulators.
What tips would you give? Would you ask? Well, for parents that are starting to see some of these signs to kind of we're struggling here today, aren't we?
I,
There,
I think that we have strong winds here, so the internet
yeah,
is on and off for me. I'm so sorry about that.
that's okay, no problem. I just thought we'd jump into some tips for parents that are, noticing some of these signs that were talked about in their child, and how to kind of help them along that journey. Maybe even before seeing an SLP, how they should be doing that at home.
Yeah, so you were asking about what are some tips as far as for speech or feeding, or what was it?
So yes, for development of sounds and motor function, yeah. So what would you say the parents could be doing to help their child along this development um, kind of cascade?
Yeah, so it really depends on what's going on with the child. If they see that the child kind of has an open mouth posture at rest, or if they're sleeping, they can gently push, the chin up to push a tongue up while they're sleeping. They can also use straws. Straws are an excellent way to work on lip rounding, strengthening the cheeks, and it also helps retract the tongue already where we like it to be. So straws are great. Trying to see if I have it here. Another good one to increase lip seal and cheek muscle is blowing. So this is a tool that you blow through and the ball goes up and down. So that's a good one, especially for the little ones. And then, of course, using crunchy food is great. Crunchier food versus only using, maybe if they have a baby or toddler, only using purees, but using more crunchy, more solid food that will be helpful in chewing, which will help with sounds as well. And then there are tools like this chewy tube as well that's useful. So really, but as far as for the parents, just so that they don't feel like they have to buy these tools, it's really, really just using are helpful. Um, Maybe using a lollipop to have them follow the lollipop with their tongue. One other thing I often do is either rub some peanut butter or ice on the bumpy part behind our teeth to kind of help elevate their tongue. So they can definitely use a lot of cues with food, putting food like yogurt on the corner of the lips, see if the child can get it so they can move their tongue side to side type of thing.
Yeah, so you basically kind of describing that, it's like exercise for the mouth. And, I think that's something that parents, don't have a great awareness of, that, a child needs to exercise the mouth. And, it's something that really, is important through these stages, because it affects the teeth, it affects the dental arch development, it affects the sleep and breathing. But these early foundations that a parent can really establish is, you know, very helpful for children. Grace,
Hmm.
what what would you what in terms of what would you like to see? Because we've talked about this connection between speech and orofacial development. How would you see that this field and this kind of integration of the field to move forward? Like how would you say that could happen?
Yeah, I would love it, especially in grad school for the new SLPs, if they can somehow have courses where they include, dentists, ENTs, talk about myofunctional therapy more, people who specialize in sleep. I just wish they can have all these professionals just in one room, or just have a specific course on that, just to kind of talk about how it affects sleep, breathing, which all affects speech, and food and feeding. It'd be great if they can just do more of that. And, it's hard because not a lot of SLPs really understand the effects that it can have. And, some are a little bit more, they're not willing to learn as much. So I just wish more SLPs would be more open to learning about myofunctional therapy and how it can really help children as far as speech sound production and feeding and sleep and breathing goes.
I mean, it's still a relatively lesser known aspect of the dental field as well. So,
Mm.
I think it kind of speaks to the idea that this area needs to be, have broader conversation. And, there is the skills that you're describing, is just absolute gold for us in the dental chair. Like, children that function and use their mouth and have oral awareness have so much better experiences in the dental chair, because they are, they just don't have that kind of um, adverse kind of, they don't want things in the mouth and so forth. When a
Mm.
child's oral motor function is better, they do better. So
Right.
there's a host of benefits from kids having this early development that you're so skilled in. And I think that crossover between orofacial myofunctional therapy and speech is just so important. For
Mhm.
those that are for those that are looking to find more about you, tell us a little bit more about where they can find you and so forth.
Yeah, sure. So if anybody's in Los Angeles, Pasadena area, my private practice is in the Pasadena area. And if you want to find me online, my Instagram is gracefulexpression.slp. You can find me there. And if you just search Graceful Expression online, I should show up if you input Los Angeles and Pasadena area.
And there's lots of great information, yeah, on your Instagram. So I'd highly recommend people jumping on there and having a look. Grace, thank you so much for joining me today. Sorry about the wind was a bit
No,
difficult there.
thank you so much, too. I really appreciated this talk. It was so fun chatting with you.
We'll talk again soon. Thank you.
Thank you.